welcome to La Vida Las Vegas podcast. We're two physical therapists living the life in Las Vegas. I'm Dr. Erica.
And I'm Dr. Joe. We created this podcast for two reasons. First, to connect the healthcare, wellness, and fitness communities in Las Vegas. And second, to highlight all the amazing people we've met along the way.
Thank you for listening, and remember to take care of yourself.
Welcome to the show.
Thanks.
We appreciate you joining us. If you want to introduce yourself and tell us what you do.
Yeah, I'm, give like a one-liner. It's what we do in the medical field. So, Captain J.D. Wolfe, I'm a resident physician for the United States Air Force in family medicine and aerospace medicine, based out of here at Nellis Air Force Base. So, I would say resident physician, work a lot, see a lot of people, and have a lot of fun, So
that means you get a lot of sleep, right?
Oh, yeah, absolutely. Definitely.
It's part of residency.
Yeah, absolutely.
So what got you started in the medical career?
Oh, man. Let's see here. Let's go all the way back. I think it was kind of there were a couple of events in my life that kind of pushed me that way. But also I think it was a little bit of a natural progression. It kind of made sense. So I think it started back. I mean, science always interests me from, a young age. Going all the way back to like my introductory courses, so to speak. But then when I was real little, I actually had a sister who passed away. So she passed away from Hodgkin's lymphoma. So I had lots of, years and years of intimate experiences with different physicians from different specialties. And I think those those initial interactions, I think, kind of piqued my interest. Doctors are all the people, sure, that may not have brought the best news to me and my family, but they also, were there for us, right? And could really be some of the only people that could really convey that information in a way that we could understand. And I think that, looking back, like that's what really piqued my interest. I'm not a hematologist or an oncologist, which was a lot of our experiences, but it definitely, that role that any physician could really play, especially, seeing people at their worst moments, so to speak, really piqued my interest. And then kind of moving forward, all through high school, I loved biology and science, especially in college. And then I actually worked as like a ER technician that kind of gave me a kind of feel for what that looked like, or, what the, working in a hospital looked like. And I was like, this is what I need to do. This is my passion. And so then I never really looked back. So.
Very cool. But what made you want to go the military route instead of private practice?
Yeah, so that's kind of, I think I get a lot of questions, I think, from people, obviously, especially not in the military, of how, what do? You do military medicine, but also work in different hospitals. So it's kind of a convoluted picture. But I think there was always something in me that really pushed me to want to join the military and serve. I think every male in my family's probably been in the military. Going back to my grandfather, he's a cook on a Navy warship in World War II, and then my dad was a career pilot for the Air Force. So, but I think that aside, I always wanted to join the military. There's something about that, that need to serve, be a part of something bigger, that I wanted to fulfill. I think initially I was a little worried because I knew I wanted to do medicine, and I'd gotten some early advice that, hey, if you want to do medicine, then the military can dictate, where you go, who you see, what kind of doctor you be. So I kind of just waited until I basically got accepted to medical school, and the military has a scholarship program called HPSP that I signed up for, and then kind of navigated that pathway through a civilian medical school while I was in the inactive reserves, and then came on active duty once I got into residency, and then came out here. So
very cool.
So what would be the comparison? Because if not everybody knows, what the traditional medicine is like, and then what that education and just experience is like, because I'm sure that there's a lot of, you hear a lot about not getting sleep and the hours you have to work, but if we can get it firsthand from you, that'd be awesome.
Sure. So, so obviously medicine, I mean, you guys know, being in the medical field yourselves, I feel like no matter what you do in the medical field, it's a long road. But I think the traditional route, I should say, for being a physician is, 4 years of high school, 4 years of college, 4 years of med school. from there, you kind of choose your specialty, so to speak, and do a residency in that specialty. Residencies can last anywhere from 3 years, which is, on the lower end, and that's what I'm doing for family medicine, versus like 7 years, like a neurosurgery residency is typically 7 years. So it's a long pathway, and some people go straight through, meaning they do all of that education straight through, like I did, or some people take years off. I mean, I went to medical school with people that were lawyers before, and then they're in their 40s and they wanted to go back to medical school or had a different career before. And yeah, so I think that kind of traditional civilian non-military route is essentially that. I think if you're in the military, it can be a little bit different in terms of, you can potentially go into an active duty military residency like I'm doing, and those can be very similar to civilian residency, can be very different from a civilian residency depending on where you go. And then they also could potentially have the option to do strictly a civilian residency. So, I have some counterparts that are doing a civilian residency, but will then come on active duty, whereas I, essentially came right out of medical school on active duty and chose to do an active duty residency. So, that kind of answer your question a little bit. I can talk to the experiences as a resident, but I felt like, yeah, the pathway can be very convoluted and different for everyone. So,
do you want to describe the different settings that you're in right now? Because you're doing multiple things, and that's not typical.
Yeah, absolutely. I think part of that is probably, I would say part of that's the specialty I chose, right? I chose family medicine for a number of different reasons, but I think family medicine traditionally is kind of what you think of as the handyman specialty, right? So they do a little bit of everything. They are requirements as a resident to maintain the specialty certification, the board certification, is to, we deliver babies, we do pediatric care, we do hospital care, we do outpatient care, we do nursing home care. And so my days look very different from day to day. I can one day be on a labor and delivery ward on base covering the labor deck, and the next day I can be, more inpatient care, just seeing my regular clinic. I also, for me to get enough, experience as a resident, I would say I work 60 to 70% on the base here at Nellis and cover in the 99th Medical Group and cover the different roles there, but otherwise I'm downtown at UMC and Sunrise because there's a lot of you just need more volume as a resident to really hone your craft and really learn medicine to the utmost. So,
and I'm sure that those settings are drastically different as far as clientele, what you see.
Absolutely. I think traditionally myself as well as the other residents, we kind of, on base can be more, it can be very busy, don't get me wrong, but it's just a different pace when you're at a fully operational civilian center, and especially a level 1 center like UMC, right? So we do our ICU rotations downtown at UMC, and we also do our like trauma rotations down there, ER rotations, things like that. We also are in the labor and delivery ward at Sunrise, which is very busy, and the pediatric ER there as well. So in terms of clientele, yeah, it's very different. On base, I'm largely serving a active duty population as well as a veteran population. So we get a lot of VA, local VA patients who are still very sick, don't get me wrong, but it's just a different population when you go downtown, both I would say ethnicity-wise or background, but also just social demographics. And so you see typically very much more sick people, a lot more sick people, which is unfortunate, but at the same time great for learning. And you really get to see a really broad spectrum of medical conditions. So,
is there anything that surprised you as a resident, or like as a family medicine resident? You're like, wow, like that's not what I expected, or something that surprised you in your formal education, and now you're out in the field and you're like, whoa, that's not.
Yeah, I think. Yeah, so I would say yes, definitely. I would say what surprises me on the daily basis is that you spend years and years, which I'm sure you guys are acutely familiar with, but years and years studying things, and then now you're actually doing these things, and you're like, so sometimes I'm like surprised because I'll think back, I'm like, yeah, well, I just did that today. Didn't think, I used to read about doing that, but now I'm doing that. So, well, hope I'm doing it right, type of thing, but then you do it more and more and you get more comfortable with it and you're less and less surprised, right? So, I mean, and that's the point of residency, but, I think outside of that, I think I'm a little bit more, I think I'm more surprised probably with our medical system a little bit. I think you always hear, at least in medical school, we talk about people or the medical system and how our American medical system can be flawed in some ways and where it's good in other ways. And I think I'm kind of like constantly more and more surprised. Like I kind of relate to that more and more. I mean, it can be very frustrating, in today's medical system being any kind of physician, but I think also in particular being a primary care physician, someone who's quote unquote on the front lines, meaning that they see, you see people probably the most regularly and see people kind of first. You're kind of the first line of defense, right? People get sick or they have some problem and they automatically usually go to unless it's emergent, go to their primary care physician. So, I think, we all, regardless of the different reasons people get into medicine, I think ultimately when you boil it down to some degree, it's obviously to help people. And I think that gets challenged over and over again. And I think that I can go on a tangent totally about, physician burnout and all these types of things. But I think some of that's probably wrapped around the fact that sometimes our medical system, although it's really great in some ways, it's kind of not necessarily set up. I mean, it's for profit, right? So sometimes it can be set up to not necessarily have the patient's best interests. And so I think as a physician, where that's your number one goal is to have the patient's best interest, can be a little frustrating. But
yeah, it's interesting too. I think that if people better knew what medical professionals did, they could go to the right source a little bit quicker rather than using like 911 as your primary care function. Absolutely. So because that uses up a ton of resources and people don't really understand that that's a thing. But
absolutely,
sometimes I would think having better education for people to know that you don't have to go to the ER when you have a tummy ache. Like you can go to urgent care, you can go to these other things. Yeah. I think that would be helpful. But that's one thing I've noticed just being a hole or gap is that people don't know where to go for certain things.
No, absolutely. I think, I'm not an ER physician, although I do train and work in multiple ERs. I think so I can kind of see both sides, and I get why ER physicians are frustrated, right? Because people do treat the emergency room often like a primary care visit, and there's a lot of issues that go to the ER that are not necessarily emergent. Some of that is probably a byproduct of our system. People don't have regular, we call them PCMs, primary care managers, right? Either they can't afford it and then they know the ER is going to take them, or they, like you said, they just aren't aware that this is who I should be going to, right? And so I think some of that's education, some of that is access. And to me, I stay out of the whole political debate and all this kind of stuff. To me, that's not my where I choose to put all my energy and focus, especially right now, this early in my career. But I know there's not a quick fix. There's multiple ways to go about helping with access and different healthcare models. But yeah, I think some of it, right, is education. Some of it is saying, hey, treating things on the front end with preventative medicine, which in the long term and in the end goal is preventing overall ER visits and hospitalizations and preventing, end stage of a lot of chronic conditions. So,
I think, have you noticed too, as you become a medical professional, some things seem so common sense to you that you almost think that everyone else would know this thing. So I've talked to people before and they're like, you mean I shouldn't eat like Pop-Tarts all day? And they're really surprised by that. But it's food, right?
Right.
Well, kind of food. It's food made in a lab, but
I hear you.
Yeah.
We have this huge, I forget the term, but just overall health awareness is just like, yes, there's a lot of, I have to bite my tongue, and say, why are you doing this? Or wait, you don't know this type of thing. But I'm also have to bite my tongue and realize that like I fortunately had the opportunity to go to school for this long. It's like I know these things and they seem common sense to me, but sometimes you have to really kind of meet the patient at where their level is at, whether that's not understanding Pop-Tarts are bad for you, or whether that's drinking a lot, or whether that's, whatever it is that's causing their body harm and their overall fitness to be poor, their overall health to be poor.
So one of our friends who's a PT now, he went to school with us. He was a personal trainer before that, and he had a client that he was training, and the guy made progress to a certain point, and he had helped him find a nutrition plan that worked for him and all that. Not necessarily prescribing him a diet, but just like helping him understand that eat real food, it's just general rules. And then the guy got to a point, and he's like, I'm not really making any more progress anymore. I've increased what I can do during the workouts, but still like have a little bit of extra weight I'm trying to lose. So he's like, let me be a little more thorough when I'm talking to this guy. Starts asking him. He's like, oh no, I'm eating healthy, eating real food. And he's like, well, what do you drink during the day? He's like, I drink about 2 liter of Coke a day. Oh. And the guy had no idea that he thought that the eating well is really the important thing. He didn't realize that a drink could make you gain a lot of weight. And he's like, oh, just stop doing that.
Which is such a common sense thing to us, right? But
exactly.
In the same time, it's like, well, sometimes it doesn't. I mean, people don't realize. So
that's just taught me, as least as being a practitioner with what we do, to be as thorough as I can and don't assume that other people always know things.
No, absolutely, and not coming off as, oh, I'm talking in the clouds, and I obviously went to school longer than you did and have this, but like really, I think that's the art of being a physician. Sometimes is really, or any medical provider, is not talking above a patient. I try to. I think that's kind of an interest of mine. Is that like doing different things to not come off, because people honestly, they don't like the doctor. I mean, I don't like the doctor. I don't like going to the doctor. Like I don't go to probably the doctor, frequently enough, like the once a year visit. Like part of that's time. Part of it's just like, it's like the dentist. Like I hate going to the dentist. Right. So, so you have to combat that, so that people open up to you, so you can figure out how to best fit their needs and their overall healthcare plan. Because ultimately they're in charge of their healthcare, right? Like everyone, and the onus is on them. And I often tell this to patients, right? Like I'm a consultant. I have the knowledge to help you, but like you're the one that has to make those decisions, and I'm here to help you. And part of my job is figuring out how to do that, and trying to figure out how to do that with someone who's already either had a bad experience with a doctor before, or previously just has something that's like that keeps them guarded and things like that. So, things like sitting down when you're talking to a patient. When I go when I'm rounding at a hospital, like I try my hardest always to sit on the bed with the patient, or don't use all this medical jargon, and really try to make things simple. Not to say that someone is unintelligent, but it is very I think off-putting to a patient when you're talking about electrolyte levels and your CBCs and hemoglobins, and they're like, I have no idea what you're saying, So I don't think we as physicians or as healthcare providers in any form are aware of that enough that we often do, especially when we're in a hurry and we're trying to get things done, So some of that kind of stuff really interests me, because you can really find out a lot about a patient that maybe they've never even told healthcare providers before. Whether that's a traumatic experience or whether that's the 2 liters of Coke they're drinking, and part of that is just kind of breaking down those barriers and really forming that relationship. So,
yeah, it's definitely the know your audience phrase really comes into play with that, because like you said, you don't want to talk down to them, but you also don't want to treat people as if they know nothing. So, like trying to gauge them in that first minute of like what their level of understanding is, and trying to match that. I think that's part of the fun of the art of the job.
Yeah, it's definitely a skill
for a reason.
Yeah, absolutely. It's definitely a skill, and a skill that just takes time, and you're gonna mess up more times than not. But the more you do it, the better you get at it. So,
we've talked before about preventative medicine is something that you're really interested in. What does that look like to you? If like it was an ideal world and like everybody had this, what would that look like in terms of like, what is preventative medicine?
No, absolutely. I mean, if I had to sum up what preventative medicine is, I mean, there's so if you let me rewind, and granted, this is my limited knowledge on the subject. It's just something that really interests me, is kind of human performance, preventative medicine, optimization of just who you are as a human being to make you the healthiest person you can possibly be. So if I had to sum up PrevMed, that's what it is, right? It's stopping things before they happen. It's leading a healthy life and really a balanced life so that you can excel as a person. Because I think right now, you know, the medical system, like what does that really look like? We can talk about, have the political debate about, you know, who has healthcare or like, you know, what's the best healthcare model, but like, what does it look like on a day to day? And to me, what I'm finding out as I see over and over again, I'm treating patients for chronic conditions, which we have good treatments before, but I'm like, you know, could we have just prevented this? You know, like, and answer is yeah, we could have, and we can. You know, so you know, when I have if I have my typical 50 to 60-year-old patient with diabetes and high blood pressure and high cholesterol, part of that is I'm preventing the downstream effects of that. Sure, that's a form of preventative medicine. So I'm having them on cholesterol-lowering medicines and antihypertensives and all these types of things. But if I also have my 20-year-old patient who's healthy with no chronic medical conditions, I'm still asking them, what's your diet like? What are you doing for exercise? You know, are you training too much? Are you training too little? You know, because I see the downstream effects of that, right? Because I'm also treating 50 and 60-year-olds that probably if they started when they were in their 20s and didn't do all these, you know, having a poor diet or smoking and drinking too much or, you know, whatever it may be, then they probably wouldn't necessarily be at where they're at. Now, some of this you can argue, right? It's the nature versus nurture argument, right? People are predisposed to things. That's life. That's genetics, right? You know, my dad was put on cholesterol medicine in his 30s. My cholesterol level is fine now, but who knows what it's going to be, you know, in my 30s. So some of that is inevitable, but knowing that you can make lifestyle changes to help prevent that. You know, it's like, for instance, you know, when you look at we talk about diabetes and blood pressure management. We always talk about the first line before you start medicines. People throw out the term lifestyle modification, right? Well, what does that mean? Well, it's eating better and exercising, right? Well, that is shown to lower your blood glucose level and your overall blood pressure more than some of the medicines that we have, because that's truly what's going to help prevent this disease and the long-stream or long-term effects from that. So to me, that's what PrevMed kind of consists of and what I really try to focus on, because, you know, I can throw medicines at people all day, you know, but to me one, sure, like we kind of talked about earlier, you're putting a hole, you know, you're plugging the hole, you're not fixing the leak. Well, what if the leak, you know, you fortified your boat, you know, early on so you were less likely to have leaks. To me, that's PrevMed. I think so that's kind of an interest of mine, but also kind of pairing that with what I get to do in the military is kind of where my passion lies. And I think honestly where I'm going to guide my career with aerospace medicine, flight medicine, and really working with people that are doing the mission in the military, the flyers and the operators, because those are the people that are highly motivated, you're right, because that's their career, that's their life, that's what they love to do. So they're highly motivated to be as healthy as they can. And when you have a patient population like that, you can really do some fun things and tweak things and do things in that population that you otherwise maybe couldn't. So.
You want to tell us about flight med and aerospace so people understand what those terms mean?
Absolutely. So, so aerospace medicine, big fancy term. So what does that look like for me? So traditionally, now this is speaking kind of strictly to the Air Force, which probably has per capita the most flight physicians, because obviously that's kind of our mission is to fly planes. So, there's kind of different routes to go about that. So the role of a flight physician is traditionally to be paired up with squadrons of pilots, or it really started with squadrons of pilots, to have a physician to really embedded with that group of individuals to make sure that they are healthy enough to do their job at all times. So, and the purpose of a flight physician, right, is to be really kind of learn what your patients do, experience what your patients do, so that you can better provide healthcare to them. That's the role of a flight physician. That has been expanded in the Air Force as the Air Force has grown. So, right, so we no longer just fly planes. We fire missiles. We have a whole space mission. We have special operators. We have air combat controllers. So we have TAC-Ps and PJs and all these people. So all of these individuals, all the people that are truly the flyers, the operators that are doing the mission, fall under the purview of flight medicine in the Air Force. How going about how you get there is different for different people. Traditionally, the Air Force has had a lot of flight physicians that are categorized as GMOs, General Medical Officers. So they went to 1 year of residency or intern year, after which time you can apply to get your medical license. And they finished that year, and then they said, hey, either they didn't like what they were pursuing, or their overall goal was just to get to flight medicine as fast as possible. And so they got to flight medicine, and they've been doing that for a while. So the majority of flight physicians, I would say, at least half, maybe a little bit more than half, in the Air Force are GMOs. The Air Force recently, over the past, I would say, 5 to 10 years, has kind of started up a new pipeline to get flight physicians trained up as quick as possible, because I think they're kind of wisening up, because they're looking back and saying, hey, it's probably not smart to have a bunch of, essentially, we call them interns, your first year residents, which not saying they don't know anything, but they haven't had this full residency and board certification process. It's probably not smart to have those individuals taking care of the people that are flying the multi-million-dollar aircrafts, or going downrange and doing the dangerous missions. That we should probably have some more specifically resident trained physicians. And so that's the pipeline that I fall into. So I chose before residency, once I graduated medical school, said, hey, I'm doing family medicine, but I want to, when I finish residency, I don't want to do just a regular family medicine job in the Air Force, which is predominantly clinic, or you're in an academic center. I said, hey, I want to do aerospace medicine. And so I've already accepted that position, and then, or got selected for that position. And then, so I'm billeted to fall into that after I finish residency next year. The training, in terms of training to be a flight physician, regardless of that role, is a little bit unique, and honestly, it's awesome. It's a lot of fun. You get to, it basically consists of additional 3 to 4 months of kind of intense aerospace medicine training. So you're learning about the physiology of flight. You're learning how to fly. I get to go up in a Cirrus SR-22 and got about 20 hours of flight time. In that, I got to go up and I got to fly a helicopter. I got to fly an acrobatic plane, and do barrel rolls and loops and all these types of things. I got to do the F-16 profile on the centrifuge, so pulling 9 Gs for multiple minutes, which was an experience. And then you also are learning about all the medical conditions that can prohibit a flyer from flying or an operator from operating. And then the ones that are not so serious, right? So like a sinus issue, right? Like sinusitis, super important to know that about a flyer, right? Because they can have like ear lock, they can, have excruciating sinus pain that can, honestly, there's been really bad accidents that have happened because that pain is so pain. They can't, when they go up in altitude, and they can't get down, So, most physicians probably wouldn't realize it's such a big deal for a flyer, right? Or what does it look like to have rapid decompression at 50,000 feet in a U-2? Well, most physicians don't know what that is, or what that plane even does. So it's learning all these types of things that really make a flight physician unique. And then you also get to fly, and it's really fun. And the reason for that is there's a big barrier between people doing the mission and the medical providers, because the medical providers are the only people that can instantly, with a snap of the fingers, tell that person they can't do their job anymore from a medical standpoint. And so you really have to, talking about breaking down barriers and knowing your audience, you have to be one, good at your job, but also tote that line of mission first, but also knowing who your audience is in terms of getting them to open up to you and really say, hey, I can come to you with the things that I need to that are bothering me from a medical or mental health standpoint, and that you're not just going to burn me and say, not listen to me and blow me off and make me DNF or do not fly. but you're going to really work with me to make sure I can do the mission to the best of my ability. So, yeah, it was a long-winded answer to your question. Sorry.
That's good.
That's awesome. And then who else is in that part of that team, right? Because you are trained maybe in a certain group, and then who else is on the team to work with you and help provide some of this care?
Absolutely. So on the enlisted side, we have independent medical technicians, which are essentially like, hopefully if they're listening, they won't get offended. They're like souped up EMTs because they have EMT training, and some of them work in clinics, some of them work out in the field, but they can do a lot more than just a regular EMT. I mean, some of the IDMTs that work with the Special Forces teams, I mean, they can do, crikes in the field and things like that. So, but you'll find IDMTs in your flight med clinics that can help you do minor procedures and all that kind of stuff. In terms of, you also have flight nursing. So flight nurses are honestly very unique to the Air Force. So flight nursing honestly operate almost autonomously from flight physicians. They own the aeromedical evacuation mission. So a flight physician, something that is pretty unique is, pretty much anywhere in the world, they can call in an aeromedical evac. It doesn't matter where you are. If you call, like the Air Force is going to work their hardest to get whoever you're responsible for out of that zone of combat or austere environment to get them the medical care they need, and they'll use any aircraft that's in the area to do it. The flight nursing honestly owns that mission. They're the ones that are transporting people on the flights, as long as they're not critically ill, transporting people on the flights and run that whole mission. So that's pretty unique as well. You also, more so in the special operations community, you have, honestly, this is a recent development in the last 5 to 10 years. It's called HPO units, Human Performance Optimization units. So you'll have physical therapists. You'll have usually a sports doc. So some physician that basically went to fellowship, whether that's out of an ER residency or out of a family med residency in sports medicine. And it's all about, prehab and rehab and how can we make sure, these guys are ready to take it to the enemy 24/7, 365. And that is a very awesome role that I've definitely heavily looked into. I don't know if I really want to go to fellowship at this point, but we'll see. I think out at the PJ units here at Nellis, they have their HPO unit is like unbelievable. Imagine like the nicest CrossFit gym here in Las Vegas, and then double it, and that's what the PJs have access to. They have, and then from a rehab standpoint, they have, I think, 2 active duty physical therapists out there. And then they have, the anti-gravity runners, they have the whirlpools and everything. So it's pretty remarkable. And I think the military is really getting smart, which makes sense. I mean, it's far cheaper instead of saying, oh, well, this guy's hurt, let's kick him out of the military, let's get the next guy up in the pipeline. It's far cheaper because it takes a lot of money to train an operator to do this unique job. It's far cheaper to prehab and rehab these guys and just prevent that injury from the get-go. So, yeah.
So there's let's talk about labs, right? Because when you're looking at as a primary care or internal medicine, like you typically look at labs, but those labs or certain results, like say for your hemoglobin, has a certain lowest and then the highest, right?
Yeah.
But that's based on a research that has done,
right.
Like this is a normal, let's say like an average American person has this average, right? So that's what it's based off of. How can you optimize that when you're thinking about the healthiest people and the top performers in the world that you're looking at? How do you look at that in terms of you see someone's labs and you're like, all right, this is kind of can go from you're not quite at that highest level. Like how can you optimize that in terms of like what's going on inside of your body?
Yeah, I mean, that's a tough question. I would say labs, sure, are based on research, but they're also based on your lab, right? So for instance, at Nellis, right, like I see people in clinic, I send off labs to our local laboratory. Well, they set reference ranges for labs, right? So a low and a high. Those are honestly based off, sure, averages of people and research, but they're also based off if this lab ran this test 1,000 times, what's the normal level going to look like for that particular lab, and that's kind of how they get their reference ranges. So sometimes it can burn a physician or any healthcare provider if they don't know their lab's reference ranges. So if you go to can't harp that enough. If you go to a new facility, know the reference ranges. For instance, the troponin, right? Troponin's released when your heart is being injured, lack of oxygen. Well, when that's released, it's very important to know if that's a detectable, it's high, or even present period. And troponin labs are notorious for like the reference ranges looking different at Nellis, where I'm mostly at, versus when I go downtown. So, you have to know those kinds of levels. So that's important. But in terms of like optimization, I mean, to me, it's all about looking at the patient, right? So you never treat a number, you treat a patient. So if I have a young, healthy guy here in front of me, or female in front of me, okay, well, if some people would say, oh no, I'm trying to think of a good example here. If your labs may be borderline or something like that, I'm like, well, this guy, is like an elite athlete. Okay, I'm not worried about his borderline, hemoglobin level or whatever it is, right? As it composed to, if I have a patient who's like a 60-year-old who's not very healthy, while I'm looking at that, that's a totally different lens. I'm looking through those types of lab values. And does that kind of answer your question?
Mm-hmm. Yeah, for sure. Because I mean, you look at labs, and that's what people want some of the blood work done on like a yearly basis.
Yeah,
and
absolutely.
Sometimes it doesn't. Like I'll take my friend for example. She had like a thyroid issue, but her thyroid was testing normal.
Mm-hmm.
But then like if you go into a little bit more of it, and she was like having like fatigue problems and all this stuff.
Yeah.
She actually went into a little bit more of an endocrinologist, and then they tested it a little bit more, and then like, oh yeah, you have some Hashimoto's issues. But that's something that only a trained person can look at those. Like that's kind of odd, right? And be able to figure out like, okay, it tested normal, but these are the things that you're describing, and that's like how you can dive a little bit deeper into what the problem is. So that just talks about.
No, absolutely. I think in that case, right, it's all about treating the patient, right? This patient's telling me they're having these symptoms, so I should probably just not blow off this thyroid lab, right? Or I should maybe get some additional labs to say, is there something else that I'm missing here? I think we too often say, oh, this is a normal level, and just move on. But in reality, like, listen to your patient. So I think that's always something I constantly try to remind myself. Talking about like annual labs and stuff. So there's guidelines, right, to get lipid levels and just regular routine blood work. But I think there's some really cool research out there, which I don't know enough about, but looking at different things like human performance, getting labs on all these guys that are essentially elite athletes, and like, is there something, can he or she change his diet to reflect a better lipid level, or a better A1C, or a better hemoglobin level? Like, what's their training look like? What is their hemoglobin? How's their oxygen carrying capacity compared to the amount they're training, type of thing? There's some really cool research out there. In fact, I used to be on a project. I love research. I think it's clinical research, I should say. Kind of a passion of mine too. And there was an ongoing study I kind of lost track of, but they were basically looking at, these guys that get injured, orthopedic injuries. If a PJ or a SEAL or somebody gets injured, like tears an ACL, MCL, something like that, or needs like a knee, like arthroscopic, or a knee replacement, heaven forbid, you're looking at a 6-month window. That person is at a minimum 6 months that you've lost. And probably another year before he can deploy again. So we're like, what are we missing here? Is there something that we can rehab these guys faster and get them back faster? And so we have good evidence for HGH, human growth hormone, to help with the rehab process and the healing process. It'll be a cold day in hell before the military in general approves any kind of HGH or supplement like that boosts anything in the Air Force or in the patient, just because I think the big fear, they always have a big fear of creating these super soldiers, or genetically altering something. I don't know what the fear is, but they have started to look at testosterone. So very low dose testosterone that doesn't have the cardiovascular effects or the endocrinologic effects on the body, but can stimulate and inhibit myostatin and all the chemicals that really prevent your body from healing quickly. So that's kind of an ongoing study that they're looking at. I don't know how far along they are now, but it's very interesting. That kind of stuff's out there, and I think it's going to be more and more that we're going to see in this whole human performance optimization field. So
in our field, they've one of the new things, well, I don't know if it's new, but one of the things that's becoming bigger is blood flow restriction, and they've been using that for a lot of injuries,
Absolutely.
and apparently it's been getting really good results.
Yeah, absolutely. In fact, one of the control groups for this study was doing traditional care, not using, testosterone or blood flow restriction. Another group was just using blood flow restriction or adding that component to the rehab process. And the next arm of the study was adding testosterone and seeing kind of how all three affected. So it's pretty interesting.
So what brought you to Las Vegas?
Oh, good question. So honestly, the military. I mean, I think that's the easy answer. But I kind of had a choice, I would say. So I knew that I wanted to do an active duty residency in family medicine, and for active duty purposes, there's only 7 programs in the country: Vegas, outside San Francisco, St. Louis, Destin, Florida, Omaha, Nebraska, and Washington, D.C. And so I might be missing one. But you kind of get an opportunity to kind of rotate those programs while you're a medical student. So I spent a month out here in July of 2018, I guess. And I was like, Vegas, I don't know. One of my buddies was like, you need to go just check out the program. It's a solid program. I was like, whatever. I don't ever picture myself living in Vegas. And then I came out here, spent a month, and I stayed on base, but traveled like all over Vegas, tried to really get the feel of the city, and just loved it. Like Vegas is, if I had to sum up Vegas, it's convenient. Like it's to me, it's pretty, and it's a fun place to live. Don't get me wrong, but like there's anything you could ever possibly want or need, Vegas has. Like it's just weird. You're like, oh, I wonder if there's this. Yep, it's here. And there's always something to do when I get off. If I work a 36-hour shift or a 24-hour shift or whatever, and I'm getting off at 7 a.m, and I'm like, okay, well, I'm wired. I don't necessarily like I have the next day off or whatever. Like there's something to do at 7 a.m. Like things are open. There's something to do. Travel's cheap out of here. Tons of outdoor stuff. So I think to me that kind of sold it to me, but also. Just the program, the residency program is phenomenal. So kind of a mix there.
So what are some of your favorite things to do in Vegas when you're not sleeping and in the residency program?
It's funny you say that. I think residents love to complain. I'm guilty of it too. Like we're like, oh, our life's so hard. It's so miserable. Like I'm like, okay, there's literally so many worse things that I could be doing with my time. And like I have a blast. Like, sure, I work a lot. I'm tired all the time, but like I'm doing the job I love. I wake up today, like in the morning, and I'm like, I get to work. I'm like, I get to do this, this is awesome. So that being said, tons of people are saying, oh, I don't have time to do this and that. I'm like, you make time. Sure, you may sacrifice some sleep, but you make time to do fun things. So I think I love, honestly, I didn't do any kind of winter sports until I moved out here. My buddy was like, you need to ski. And so I just picked it up. I really only skied one other time in my life, and then kind of picked it up, got an Epic Pass, and I love to, wintertime. I've been to Tahoe, I think 3 times since I lived out here. Lee Canyon, which is like, a hidden gem in Vegas. I went down to, or over to Park City, so love skiing. Love, being social, going out with friends, kind of doing the brewery trail type of thing. Recently moved in December downtown. I was living up in North Vegas, and then I got an apartment in downtown, kind of Fremont area, Arts District. So, I can just leave my apartment and walk to wherever I went and go kind of experience kind of the culture of Vegas. So, love doing that kind of stuff. I love hiking, doing anything outdoors, Mount Charleston and Red Rock and all that kind of stuff. So,
what's your favorite thing to eat in Vegas?
Oh gosh, there's so much. I love pizza. I'm kind of obsessed with pizza. So my colleagues would give me a hard time, but I love pizza. I love trying new pizza. And if there's like a new pizza joint that opens, I'm like there, just like I love trying new types of pizza, that type of thing. So, but that's another thing about Vegas. Like you can, if you want to go eat at a 5-star restaurant every day of the week, you could. I would not advise your bank account would probably suffer, but if that's what, if you want to take time off and go like truly see what that experience is like, I think everyone should try to do that at least once. So, but favorite thing to eat right now is Good Pie Pizza in Arts District downtown for sure.
That's your favorite pizza out here?
Yeah, right now I would say so. They opened up this year, so they're relatively new. There's also a new pizza place that opened up across from my apartment called a Yukon Pizza. They started this thing called Nevada or Las Vegas Test Kitchen. So they have like chefs either off the strip or just local chefs will like rotate through and just do like a pop-up, and they'll make whatever their food is. And so there's a pizza joint there that opened up, and they do like sourdough crust pizza. So good.
Oh, well, you have to try that out.
Yeah.
It's definitely worth it. Reasonably priced, really good.
And that was called what?
Yukon Pizza.
Yukon Pizza.
Yeah, it's down right next to Ferguson's on Fremont downtown. So,
what's the topping on your pizza?
Oof. If I'm like trying a new pizza place, I'm telling you, I get in the weeds with pizza. So if I'm trying a new pizza place I've never eaten there before, I'll just get like a regular cheese or regular pepperoni, because then you're like you're setting the standard for everyone, right? So like everyone has like a regular cheese or pepperoni. So then you can really like, okay, is this pizza just good because I love the toppings on it, or is it this is like the crust is good, everything about this pizza is good, So that's usually where I start, but I pretty much won't. There's no pizza I probably won't try or at least eat all of. So the Good Pie actually they have a chicken parm pizza, so it's a Detroit style thick crust, and they put chicken parm inside the pizza.
Like in the crust?
No, like it's like a piece of chicken parm like inside a pizza slice.
Oh, wow.
It's pretty crazy. It's pretty nuts.
We'll definitely have to be trying that later.
Yeah.
So what's something that you've learned, but you wish you knew it sooner?
Oof, that's a tough one. Something I've learned I wish I knew sooner. This is probably a cliche answer, but just money. I mean, I don't know a whole lot about money now, but I wish like growing up, my dad did a great job in terms of, and he continues to do a great job of just being like, stressing the importance of money and being like, you pay yourself first, meaning, you pay off your debts, or you paid off, you save money, whatever that is. And he's always done, but I just wish I knew, because I took no business courses in college, no business courses in high school. I took, in medical school, we took like a medicine business course that and I've read a couple books, and that's kind of what I base my current very minimal strategies on. But some of my buddies just know all this stuff, and that's like their hobby. And I don't know if I would take it that far, but just more, knowing what I know now, I wish I knew just way more about money and economics and saving and different accounts. Because now it's like my brain, there's only so much room in there for medicine stuff. And after that, I'm like, okay, I'm not going to remember that. And so I feel like finances is one of those things, and I wish I just knew more. And I probably will, just take time.
Yeah, just like any other thing, learning something new is definitely that. What's
Yeah.
something you commonly see, in whether it's your practice or your daily life, that you wish more people knew?
Wish more people knew something that I encounter daily. I think sometimes I wish, and there's no way to go about this. Sometimes I think just because my daily life is seeing patients right now, I think it's very hard to convey to a patient that, that the time that I spend with them in the clinic room is not the only time that I devote to them. And I try to convey that, but there's the note writing, which that's inconsequential, but like the time I spend my clinical thinking about how can I best help them. And there's just a hard way to convey that. I wish patients knew that, like, the time that my 20-minute appointment I have with you, which is the standard, like, there's, more outside of that I'm devoting to you, and I think it's very easy sometimes, and patients, they say, well, it's just the 20 minutes. That's all you really, and that's not true, but you also don't want to say, raise your hand and be like, poor pitiful me, like all my patients, just think you don't spend that much. But I don't know. I think it's just part of that doctor-patient relationship. I just wish, doctors do, at least if they're a good doctor, do spend a lot more time than you think devoted to their particular case or their problems that they're having in their healthcare. And I think it's very easy, given our current system and about how fast we have to see patients and who dictates that, for that to get lost. But it's also a two-way street. I think doctors have to do a good job of saying, and medical providers as a whole, not just doctors, of saying, hey, like, this isn't just the time I'm spending with you. Later I'm going to be here thinking about what else can I do? What else do I really think is going on with this patient, or how else can I best help them? So
it's interesting. Do you find yourself too at other times, like when you're eating pizza, for instance, thinking of something for your patient, you just kind of realize something, or, next time I see him, I really need to ask this, because that might have been an important piece of what they have going on.
Absolutely. I think that moment for me most commonly happens when I lay down at night, because my day, I'm going 100 miles an hour, my brain's going 100 miles an hour, but when I lay down at night, I'm like, well, what, I start reliving some of the things that happened that day, and I think sometimes I'm like, man, I probably should do this, or what about this? Am I doing, and I'm not second guessing myself. I think I'm looking at what else can I add, and sometimes it keeps me up at night. But I think that's just a natural thing. You just, we being in the medical field, you're thinking about how else can I help this patient, or better yet, is there like a more interesting, like, I rotate through the inpatient wards on base, and we see a lot of interesting cases, especially with some of our veteran patients, who are exposed to things like Agent Orange, and they were in Vietnam and Korea and have these crazy diseases, and then I go to bed at night and I'm like, man, that was crazy. I remember learning about that like once, and it wasn't even the topic. It was just like some anecdote, and it's like those types of things I definitely think of and jot down and journal about and things like that. So
something unique that you're trained in as well, and it's probably not as common in the Western medicine, is acupuncture, right? So tell us a little bit more about, how you incorporate that into your treatment.
Yeah, absolutely. This is definitely something that if you would have asked me, definitely in medical school, but even like coming to residency, if this is something that I would do, I'd have been like, no, what, acupuncture? No way, not that, well, yeah, I mean, I'll say I was like, this isn't medicine, and part of that is a byproduct of how I was trained. I've only been in a Western medical system. I went to a Western medical school. I'm an MD, not an osteopathic doctor, which I just think that osteopathic physicians have a little bit more uniqueness to their training, in that they don't just always learn things by the book. They do more chiropractics, things like that. So they're probably more open to the idea. But being from a traditional Western medical school, I never even gave that a second thought. Then fast forward, coming to residency for the Air Force, Nellis is pretty unique in that they essentially, some of the founding men and women of that program actually got on board and started training residents in formal acupuncture through an organization called HCOS, which is really the Western, it's a worldwide organization, but has a lot of Western trained physicians that are acupuncturists. And so they kind of, formed relationships through that program and started training residents and other physicians in the Air Force to do acupuncture. And then fast forward probably 10 or 15 years, and now this is a standard where there's residents specifically, not just family medicine, but predominantly family medicine from all over the Air Force and really the DoD. They're coming to receive this training. And I think some of this was born out of, in military medicine, you have to be, for active duty members, you have to be very cognizant of what medicines you give them, even what diagnosis you give them, right? Because that's on their record. And there are certain things in the military, unlike the civilian world, where you just can't be in the military. Things that are honestly chronic and going to deteriorate, you're just not going to be allowed to either be in the military, or if you have a specific job where you cannot perform that job anymore, you're going to be forced to retrain into another field. So you can imagine if you have pilots and operators, anything, you have to be very cognizant of what you prescribe them, and what you really diagnose them with. Not to say that you're going to not diagnose them. It's just that you have to be in your documentation, you have to be pretty careful. So that being said, obviously chronic pain is huge, not just in the military world, in the civilian world as well. And in the military, I mean, you got to imagine like the deployment requirements just to deploy, no matter your job, is you have to be able to like run 100 yards. You have to be able to carry like 40 to 60 pounds. And those are just kind of baseline requirements that everyone has to be able to do. We can imagine if you're holding everyone at that standard with people that sometimes may predominantly do desk duty or they're not the most active, right? Like chronic pain's a big issue. And I can't just throw narcotics to people, not just because they're in the military, but also because that's a horrible way to treat pain, right? We've learned those lessons, right? I think our medical community single-handedly caused the opioid epidemic, right? So I think we've learned our lesson there, but we've constantly looked for other avenues to help patients that aren't those things, right? There's been, the physical therapy world. I mean, I think, in my opinion, it's probably been at the forefront of some of these things. It's been, chiropractic, but just more like osteopathic, prehabbing, this whole philosophy of, really goes along with preventative medicine, stopping things before they really occur or manifest, has been huge. But that's how I think acupuncture in the military, that same philosophy and mindset is what it was born out of. And so that kind of led to us being trained. I think the course that is offered is approximately like a 200 to 300 hour course to be a fully trained acupuncturist. Or I should say, really, to be a fully trained acupuncturist, I think you have to go longer than that. But the course that I received was 200 to 300, and I can pretty much do all the bread and butter acupuncture treatments, which is a lot. And so in my experience with it so far, I've probably been fully, received my certificate for the past 3 to 6, or no, it was like 6 months, I guess, and has been honestly pretty great. I think when I first started with acupuncture, sure, I was hesitant. My Western brain, Western medicine brain was constantly challenging like every idea that was kind of coming across. It was really like this physiologically, this makes no sense, but really you have to take a step back and really think outside the box and really retrain the way that you view things. And now it's kind of like, sure, there are some parts of acupuncture that I don't fully understand. And part of that is probably I just haven't spent enough time delving into all the different facets of acupuncture. But I can tell you that my belief in it is constantly reaffirmed every time I use it. So what is acupuncture? So acupuncture is an ancient Chinese form of medicine, and you can go back into the different dynasties and look. This has been around for a very, very long time, thousands of years. And the reason that it has been around so long, I think, is that it works. Right. And so the predominantly how I use acupuncture is mostly, I would say mostly to pain. So I have my, either active duty, non-active duty, just whoever comes in with, say, chronic back pain, which is like a lot of visits that I see, right? I have different treatments. Some of them involve, needling, like we talked about earlier, paraspinal muscles. Some of them involve, hooking up electric current. Some involve, honestly, points that, if they come in with low back pain, I might be needling, fingers, hands, feet, body treatments. It's all about what the patient comes in with and the different techniques that I know to work. It's also the kind of the approach that when I approach patients from an acupuncture standpoint is you learn in acupuncture that there's different systems, or I should say different levels of treatment, and you really start superficial and then you kind of go deep. The most superficial technique would be called surface release technique. So a localized problem, I'm needling, muscular layers, fascial layers, that type of thing. You can go deeper into like tendinomuscular units. You can go even deeper into what we call meridians. So that's the kind of how energy flows in your body, and the different pathways that it takes. And because acupuncture does teach, that you're needling 4 different energy points, and that often with medical problems, it's an imbalance in the energies in your body. This belief of yin and yang, different, good and bad energy, black and white, however you want to kind of view that. And so the idea with certain treatments, my Western brain looks at, hey, I'm probably, especially for musculoskeletal pain, I'm probably needling areas that hurt and releasing fascial tension, muscle tension, trigger points, all that kind of stuff. My Western brain, that's the way that I view it, and it works. Now, the other great results that I've gotten out of acupuncture involving energy treatments and filling someone up with good energy, getting rid of bad energy, all this type of stuff that most people would call voodoo. And at first, yeah, sure, I questioned it every single day. I don't know exactly how it works. Like physiologically, I can't really explain it. And I think, reading textbooks still doesn't really help me explain it, But to me, I think when I get down to it and I understand enough of it to use it to help me and help patients, when it boils down to it, I don't care. Like I go to sleep just fine at night, because I would say 60 to 70% of the patients I see that I give acupuncture leave pain-free. So, and it's not just pain that I treat. I think those are the easier treatments. So for me, it's easy to do a 20-minute treatment in a typical clinic visit. But if I feel that somebody is a good responder to acupuncture, and there's other issues, I'll bring them back for other appointments, longer appointments, hour-long appointments and treatments. And luckily, I'm at a place like Nellis that allows me to do that, and the command structure there, and the big Air Force command structure wholeheartedly believes in acupuncture, so that makes that easy. I would say, just to give a kind of a quick example, just because I feel like I've been very abstract with some of these things, is I treat PTSD with acupuncture a lot. I don't just see Air Force people. We have Army and Marine active duty members, or at least retirees, that have come and seen us. And I remember very specifically, I've had this active duty Marine, Iraq, Afghanistan in the early 2000s, saw a lot of stuff over there that he was not, which was fairly, sad. He was not proud of that he participated in. And he's the guy that, goes to a restaurant and he won't face the door because he's so on edge. Typical PTSD symptoms. He in the clinic room with me when I first met him, he's gripping his chair. He's so with high blood pressure. He's so his catecholamines and his cortisol levels are just on edge all the time. And so I could have looked at that before acupuncture. I'd been like, easy, anti-anxiety, depression medicines, put them in mental health, like see them regularly, easy appointment for me. Now doing acupuncture, I think I have a different way that I view that encounter. Sure, I can start those medicines, but inevitably a lot of those medicines take time to really, and it might take months to even a year to get him on a good regimen and that type of thing. Acupuncture, I can do the same day, and I can get him relief. There's a treatment called Dragons, which is, again, sounds very voodoo-ish, and there's all this belief of internal and external dragons. It's basically this, things that you hold on to and you relive. And the first part of that treatment is I literally tell the patient, it's like 7 points as their supine. And I tell them, I'm going to leave the room for about 15 minutes with these points in, and I want you to think about the things that keep you up at night. Think about the things that you did over there. Think, all these horrible thoughts, let them naturally kind of bubble up and come up inside. And then you take those points out, you flip the patient over, and you do similar points while they're prone. And this is supposed to be, hey, let that stuff go. Clear your mind. Get rid of, try to let go and realize, all of these things are out of your control. And you'll go back in the room, and often the patient's, bawling their eyes out because they're, reliving some of those things. But if you do that right, that patient feels 10 times better that day. And overall, we've had examples, not me personally, in our clinic where the patient never has to go on any kind of medication because this was able to sustain them and get them through their day-to-day and make them feel better. And they can come back for repeat treatments whenever they want. So
yeah, it's good stuff. And it's really, just like you said, there's a lot of stuff. Even when we take our dry needling courses, they'll even tell us, like, we don't know why this works. This is what the results tend to be. And we've definitely used some techniques similar to what you're saying, where the person will almost be falling asleep on the table, and you have to make sure that they're not like moving while they have needles in their back. You're like, hey, don't fall asleep yet. And you can tell that they're getting real tired and real quiet. But it helps you sleep really good too.
Yeah, I always love that conversation because you come from a Western background, but you learned an Eastern thing. And, from what we take in our dry needling courses, again, it's not the same as acupuncture, but the way that I think about it, it's like, okay, the nervous system is the drive to everything that we do. Like whether it's, like, if your brain doesn't work, you can't move you can't execute or plan things, or like you can't do tasks. So if you're unable to do that, then that's how we're able to create a different response. So like, if you have a hard time bending your elbow, and because something's so stiff, and then you stick a needle in there, and then now someone's able to bend their elbow, like that's insane. But it's because, again, this is again from my Western standpoint, is that we're changing the way the nervous system is interacting. Right. So it's really fun to have that point of view from you, because you still have that Western, like, man, I don't know what's happening here, and I mean, maybe we don't either, even with just the theory that we're using. But it's always fun to see those awesome stories of patient successes and having to go through that medication cycle, and you don't know if it's always going to work with the medications, right?
Absolutely. And the same is true for acupuncture, though. I mean, honestly, I have a fair amount of or have some patients that it just doesn't work for them. Either they're not in the right mindset for it, or maybe I use the wrong treatment, or maybe I don't get those results. But to me, it's worth me still doing, because I do have so many patients that get better from it. Also, from a standpoint of, I can't tell you how many times I'm kind of of the mindset, and I will probably continue to be that mindset, outside of like cancer pain, post-op pain, things like that. I almost never prescribe any kind of narcotic or even really benzodiazepine, because there's we just live in such a society now where it's just horrible how many people are addicted to narcotics, and so I'm very hesitant to do that. And then we go down this gauntlet of like things that don't work for them over and over and over again from a pain standpoint. And I'm like, this is just another tool in my tool belt. One, that does work, but two, that another option I can give to patients that now, given my kind of successes with it, I've prioritized above some of the other things that I've done. I think another great thing about acupuncture, you can literally do it anywhere, anytime. Granted, I'm not gonna like carry needles with me everywhere, but like you can do it anywhere, anytime. In fact, at Nellis, we actually get an opportunity where every resident gets the opportunity to spend a month on the search and rescue team at Yosemite. And so we go up there usually in the prime summer months, and we actually live in the park at the clinic, and then we just man the clinic with a couple other providers. And they love us up there because we bring acupuncture, and like they don't want to like go prescribe narcs to some random person they never met. They got injured up on the, so often we'll do acupuncture up there, and they love us so for it. So other things, like I spent a couple months in India back in 2019, and I love international medicine, and that's like a passion of mine. And I'll probably continue to do that. But like that I've yet to do acupuncture internationally, but that whole culture over there is built around a traditional medical system, and so I already know that they do acupuncture over there, but I'm sure hopefully when I get back over there, I'll be able and have the opportunity to do it. So
what's something you've been working on, whether it's professionally, personally, physically, or mentally, something you're excited about?
Oof. That's a lot of options.
In all your spare time.
Yeah, in all my spare time. Honestly, I think I've been really happy with being able to at least just maintain some form or some semblance of fitness. I think fitness obviously is a passion of mine, but I was very scared going to residency, because all you hear is like, oh, by law, you can't work more than 80 hours a week. And I'm like, 80 hours a week? That's still a lot. Like, what? What am I going to have? And it's still, I mean, it's probably a rarity. I hit right at 80, but I was just, with everything going on, I'm just like, man, I don't want to be that person where I'm like, oh, I just got too busy. Fitness went out the door. Like, that's crap. I hate that. And, people that, I'm not saying everyone makes an excuse. I just personally don't ever want to make that excuse. Life is people, and I'm fortunate. I don't have a family or kids here. Some of my counterparts in residency are married, and that's a hard life. I can't imagine being responsible for other people other than me. Like, treating patients, that's a total different ballgame. Like, having kids you have to go home and take care of, and people that are dependent on you, I'm like, oh God, it terrifies me. But I've been able to maintain some form of fitness. And so to me, just constantly working that, I was able to do the CrossFit quarterfinals, which I think was kind of a goal of mine to be, to still be able to qualify for that and not, as a resident who works a lot. So I felt like that was a good goal or something I was working on. Other things, let's see. I think kind of when I started residency, but it kind of waxes and wanes. Something I've been working on has been, I kind of spoke to that where I go home and a lot of times you're just like, mind's going 100 miles an hour and you can't fall asleep because you're thinking about all the things you did that day and what you may have messed up as a resident. But part of that has been reading more, like non-medical stuff. I'm always reading like journals and stuff like that, but just non-medical stuff, and just actually reading for like enjoyment. And so like, even if I'm really, really tired, like 15 to 20 minutes, which often I find that I don't even make it that long because I'm so exhausted. So always having a book going has been something I've been really working on this year.
So you read fiction, nonfiction, Harry Potter, fan fiction?
I would say nonfiction. I feel like as I've gotten older, I always liked history too when I was, in high school, but then like in college, I'm majoring in biochem. Like I haven't taken a history course in 8 years, 10 years. So I love like World War II history. I love Civil War history. So I've been reading a lot of stuff like that. So
that's definitely a good bedtime story.
Yeah, it is. Like there's, I think I'm reading a book. It's called The West or Killing the West. I think it's these killing series. It's Bill O'Reilly, which whatever you have thoughts on Bill O'Reilly aside, the books are pretty good. And they're like pretty historically accurate, I think. And it's just how we moved as a country out west, which aren't our brightest moments as a history, but it's super interesting history. So that's kind of been something I've been working on. So
excellent. And how can listeners find you?
So listeners can find me. They can definitely reach out to me on Facebook. It's just JD Wolfe, Wolfe with an E. I also have an Instagram. I think it's jd.wolfe3. Listeners are more than welcome to add me, look me up, message me, all kinds of stuff. I'm open book, so I love people to talk to people and meet new people. So,
and what do you want to leave the listeners with?
Let's see. It's funny. So I'm one of the new chief residents at Nellis, so some of this is coming out of that, I think. But we do this like newsletter. And with the newsletter, I try to do like inspirational quotes. I love inspirational quotes. So if I had to leave, it's kind of a funny one. So I'm sure people know General Mattis. He was a big Marine Corps general, and during this Iraq-Afghanistan war, he then becomes Secretary of Defense. He's got great quotes. He's like very stern, guy. And one of his favorite quotes, he's like, "Be nice to everyone, respect everyone, always have a plan to kill everyone." So that's always a good quote.
That's perfect. And we really appreciate you being on the show, JD. I feel like we learned a lot.
Oh, learned a ton.
Appreciate you
so
guys.
much.
Thank you so much for the opportunity. It's my first podcast, and I had a blast. So,
yeah, thanks. We'd like to thank you for listening to La Vida Las Vegas podcast. We hope you enjoyed the time with our guests as much as we did. It would help us out so much if you could share, subscribe, or review our podcast or any combination of the three. Thanks again, and remember to take care of yourself.